Ahead and get started here as people are trickling in. Thank you so much for joining us for today's mini lab. My name is Charlotte Stowe. I am the research assistant for the Bright Spots mini lab, and we're so glad that you're joining us today. Before we get started, we would like to take a moment to say that while we're gathered here virtually, it is still important to acknowledge that our institutions are situated on traditional, ancestral, and contemporary lands of Indigenous people. Here in Minnesota, we're gathering on the land of the Dakota. The word Minnesota comes from the Dakota name for this region, Minnesota Makoche, which translates to where the waters reflect the skies. We're taking this moment to consider their histories, languages, and cultures, and we invite you to please do the same wherever you're joining in from. Next, just a quick note about our funding here. The mini lab is co-sponsored by the Leadership Education and Training Program in MCH Nutrition, as well as the Center for Leadership Education in Maternal and Child Public Health. Both are funded by HRSA's Maternal and Child Health Bureau, and we're grateful that these grants provide us with the opportunity to come together around qualitative research today. Today's session is also being co-sponsored by the Prevention Research Center at the University of Minnesota. With that, I'll pass it over to a representative from the PRC, Melissa Laska, to introduce our speakers.
Hi, everyone. I'm Melissa Laska. Thank you so much for joining us here today. We have been excited about this presentation for a long time and are so happy that you all could be on the call. Today, we're going to be hearing about using digital storytelling for community engagement and health promotion. Before I introduce the speakers, I did just want to say that the Prevention Research Center, which I am a lead of the Prevention Research Center here at the University of Minnesota, is a co-sponsor in this work. The PRC is funded by the CDC and is located in the School of Public Health now. We continue a legacy of hosting work that advances well-being, reduces inequity, and promotes disease prevention policies, programs, and practices over the last 30 years here at the university. Our long-term goal is really to ground our research in best practices for dissemination and implementation, and really be guided by and partnering with community and other interest groups as we move forward in this work. And so we're so happy today to have Dr. Abby Lohr and Ms. Graciela Porraz Capetillo here with us. Dr. Lohr is an assistant professor in the Division of Epidemiology at the Mayo Clinic. She works toward health equity by using a community-based participatory approach in collaboration with immigrant and refugee communities in southeastern Minnesota. Her work seeks to design and implement culturally tailored interventions to prevent and manage chronic diseases and promote health screening. Graciela Porraz Capetillo is also with us today. She has participated in a number of projects with the Rochester Healthy Communities Partnership. She has served as a cultural liaison between the Latin community and the Rochester Healthy Communities Partnership. She has significant experience working with the community in Rochester, both as a certified medical interpreter and as a volunteer for a number of local organizations. She really brings her expertise in adapting research instruments for cultural and linguistic acceptability, as well as designing culturally appropriate study procedures. So welcome. We're excited to get on with the presentation, and you can see the learning objectives here on the screen. As our speakers load up their slides, Charlotte will launch a poll, I believe. So you should be seeing that appear on your screen. And if you could just fill it out when you see that come onto your screen, we'll complete that and then move ahead with the presentation. Thank you.
But we're just really excited to be here. Thank you for attending. My name is Abby Lohr, and I'm really honored to be here, everyone, today with my colleague Graciela Porras Capetillo. So who loves a good story? So if you could raise your hand or make a emoji thing and what you're, in the oh, I see lots of hearts coming. Oh, Katie Smith, I see you. Yay. Okay. So, oh, yay. So we all love a good story. And so our question for you today is, why not use stories to address health inequities? And so that's what we're going to talk about. Yep. How a tailored digital storytelling intervention developed with and for the people most impacted is an effective tool for health promotion.
Well, And we have to start with the background, right? So we went to solve a problem. Conventional health promotion programs often fail to engage minority populations, so we needed to tailor approaches because they were needed, right? And the solution for us was storytelling as an effective strategy to encounter behavior change. So, like I say, we all want good stories, and we want to find ways to achieve health equity. Digital stories are produced in digital storytelling workshops with our participants, obviously, are narrative-based videos created by individuals who live experience, who share their personal stories. Now, the storytellers, they write their own scripts, they take their pictures, they select their sounds, their music, and they participate in the video editing. The final product is an audiovisual story that, with still images and voice-over narration, that takes more or less maybe 2 to 5 minutes. And it differs from the in other narrative videos intervention because this is the individuals impacted by the are individuals impacted by the same problem or theme, let's say it, and they're central to the production and to the knowledge. Digital story workshops promote shared connections among participants with similar experiences, which might enhance the practical relevance of the stories created. Normally, they sit in a room and they share their own stories, and among themselves, they help each other with the help of the community leaders and our great people that came from California to teach us how to do these videos. To expand on digital storytelling process with participants' permissions, researchers can use digital stories as an educational tool for improving health-related knowledge and practices. These stories can be catalysts for change by inspiring viewers with similar life experience to change health behaviors or attitudes.
All right. Thank you. Yes. So our purpose today is to really show you how a tailored digital storytelling intervention developed with and for the people most impacted is an effective health promotion tool. So like Melissa said, we're going to talk you through some theoretical foundations, apply insights from some examples that we've worked on, discuss ethical considerations, and then share some tools.
waxaan imid waddankan 2004 isbitaalkii ugu horreeyay ee aan tegay wuxuu ii sheegay in aan qabo sokor wuxuu igu yiri cuntadaada wax ka bedel waxba uma qaadan waxaan doono ayaan iska cunay calwadii hilib arigii waxaan arkay waa isku gadiye sida shaay camal ii qabtay hilibka markii hore caafimaadkayga aad u fiicnaa waxba ma dareensaneen mana u malaynaynin in aan jiranahay waxaan ka walwalsanaa ilmahayga iyo shaqo 8 bilood ka dambe waa xanuunsaday hurdadii ayaa iga tagtay wareer iyo qarow ayaan isku arkay dhakhtarkii ayaan ku laabtay wuxuu isoo siiyay daawooyin aad ayaan ugu sii xanuunsaday waa ku noqday dhakhtarkii maxaa yeelay bogga ayaa i xanuunayay waxay ii direen ultrasound waxayna igu yiraahdeen dhagax ayaa xameetida kaaga jira kolestaroolkaagana aad ayuu u kacsan yahay waxaan galay qalliin markaas ayaa waxaa laygu bilaabay cirbadii sokorta oo caloosha layskaga duray 9 maalmood ayaan isbitaalka ku jiray markaas wixii ka dambeeyay dhakhtarka warkiisa ayaan dhageystay oo maqlay waxaan wax ka bedelay cuntooyinkii aan hore u cuni jiray waxaana badsaday khudaarta iyo qamadiga rootiga ka samaysan waxaan iska dhaafay baastadii hilib arigii iyo xalwadii aad ayay iigu adkeyd in aan joojiyo cuntadii dambe aan cunayo wax dhadhana way ila yeelan weyday sida cawskoo kale ayay iila soo dhadhantay ilmihii waa igu diideen ani kaligayaa cuni jiray waxba saliida ma isticmaali jirin awaajyada iyo waxyaabo kaleetan wax iskaga macaysan jiray jikinkana biyaan ku karsan jiray wax ma dubi jirin waa igu adkeed marka hore cuntooyinka in aan iska bedelo hadda waa la qabsaday daawooyinkaygana si toos ayaan u qataa wixii igu soo kordhay waxbaan ka saa'idsaday haddaan markii hore dhakhtarka warkiisa maqli lahaa
All right. So our question to you is, and please put this in the chat, share a moment from that story that resonated with you. What do you think? And I'll move this over here so you can see. I have the chat going right there. Oh yeah. I will try and press the slides. What resonated with you about that story? Her voice and hearing her speak in her language. What else?
Acknowledge cultural food practices. Be that example of how changing diet made her healthier, that she could share in her language and words. Tasted like grass. Laugh, yes, of course. Her having to adapt her own cultural food, challenges with changing your diet, yes. Yeah, a lot of the things that we saw.
Yeah. So you're kind of getting the idea on how we're her honesty and her vulnerability. Yeah, it is a really vulnerable thing to make a story. Yeah.
Of change behavior.
Courage to unlearn old habits. Yeah. So even if you maybe don't identify as a Somali woman, there are, things that impact us all. I think the different person is working on that. So yeah. All right. So I will share my screen again here, and we'll dive into our theoretical foundation. Oh, it took me back to the
video.
There it is. Okay. This was the tech problem we were having earlier, where once I stopped the video, we couldn't. There it is. Ha! Solved it on the fly. Yay! All right. So there's some theories behind this work that we use when we're applying it. So primarily two: social cognitive theory, which comes from Bandura, and social cognitive theory has it has multiple components, but there's two that we focus on, specifically observational learning, which is witnessing and repeating behaviors, and self-efficacy, which is just our confidence in our ability to successfully perform a behavior. So in this case, it's managing your type 2 diabetes. So it could be like testing your blood sugar, taking your medication, asking your doctor a diabetes related question, like your confidence in your ability to do that. And then the other theoretical model that we pull in is the culture-centric health promotion model. And this ties together two ideas. And one is the emotional connection and identification we have with others. So seeing people who are like you, and people that you can relate to, but also like having an engaging story, like something you can sort of feel like you're immersed in, and how when we see those things, they can lead to role modeling, which can cause attitude or behavior change. So together, these theories posit that learning by watching and being inspired by similar others can lead to attitude or behavior change.
And by the way, yes, a lot of the patients, they have seen the videos, they feel really, they identify with the storyteller. So that is something extremely, extremely important, because they see themselves and they can hear the same stories. But, that triggers some changes in the patients to say, okay, I need to start taking care of my health.
Yeah.
It's very, very, very nice to see that.
Yeah, and we'll get into that here shortly. So we're going to show you another clip. We have 3 clips total. There's just 2 close together. So we'll show you another digital story and then ask you to reflect on this one too. So again, if you could give me a thumbs up that you can hear it, that would be really appreciated.
No me gusta hablar de esto mucho, pero cuando yo era joven, en Guatemala llevaba una vida muy diferente. Jugué fútbol profesional por 8 años. En nuestra cultura, la responsabilidad del hombre es trabajar, traer la comida y pagar los recibos. Para mí fue muy difícil moverme de Guatemala a los Estados Unidos. Aquí tú tienes que pagar muchos biles. Cuando llegué tuve que trabajar mucho. Comía a la carrera, no comía bien y por el mismo trabajo no pude hacer ejercicios. Yo estaba preocupado por mi familia, que mi esposa fuera a un chequeo médico y también mis hijos. Mi esposa siempre me dijo que debería hacerme un chequeo médico. Siempre le decía a ella que iría después. Cuando finalmente fui, mi azúcar en la sangre estaba tan alto que el doctor me preguntó por qué yo no estaba en coma. Tenía 40 años. Mi hijo pequeño tenía 8 años y le faltaba mucho tiempo para ser un adulto. Al enterarme que tenía diabetes, me dio miedo pensar que la enfermedad me iba a cortar la vida. Trabajé menos horas para tener tiempo para hacer mis ejercicios. El cuerpo ya no es el mismo. Cuando volví a jugar fútbol, recordaba mi juventud, pero también tenía que encontrar el equilibrio para no caer. Lo que más me gustó es que pude disfrutar el deporte con mis hijos. Ellos me apoyan para que yo siga practicando y me llaman para reunirnos, para ir a la cancha. La fuerza que tengo para seguir cuidándome es mi familia. Me llama, nos reunimos, nos invitan a sus casas, me hacen comida y me aconsejan que me cuide. Ya no me inyecto mucha insulina porque mi esposa me balancea mis alimentos y la rutina de mis ejercicios. Nosotros tenemos que vivir alegres y disfrutar a la familia, como si estuviéramos viviendo el último día de nuestra vida.
How is the story tailored for Hispanic Latino viewers? So
Any
go
ideas?
ahead and type in the chat what you think.
Music first. There you go. Yes,
Yeah.
we love
Yeah.
music. We like to dance. Different images. Yes, yes. Yeah, the story of immigrating to the country. Yeah. Yes, very true.
Yes.
And then, yeah, there's something about, there you go. Thank you. Collective
Family.
effort, family-centered soccer, cultural foods, focus on food, love of football, the importance of food and family, period. Yeah. All the photos integrated his hobbies and culture. Yes, very true. Yes, supportive environment, language, sports, family, all very resonant. Yes, social norms, discussing expectation of men in the culture. Very,
Yeah.
yeah, the importance of food and family. Yeah, we talk about that. Yeah, all of them are true. I mean, it was, I worked directly with Dino and his story, and it was extremely nice because I want to add that Dino, up to now, he's still playing soccer indoors during winter time and outdoors in summertime. And he's still following a very healthy diet, and we hope that he continues the same way because it was difficult for him. But he's such a nice person, and we wish him well. So, okay, language, sports, family. And it's something very difficult for the Latinos. We have such a rich culture and so many dishes from many countries that our culture and identity is sometimes shaped around those environments, eating together, food and whatnot. But we tend to eat a lot. That's the truth. Very delicious. But
I don't blame you.
Okay. So now we have stories for change diabetes. And RECP is a 22-year partnership. In 2014, this important health issue for RECP and the community members, we saw that issue, because diabetes causes disproportionate illness and death in the Hispanic Latino community. Sometimes they seek help very late or when they are super, super sick. The community told us that the storytelling is a promising way to address perceptions and behaviors for diabetes. Co-creation of a digital storytelling intervention for diabetes and self-management. At the end of the workshop, participants created cultural relevant stories in Spanish about their personal experiences related to the physical activity, dietary quality, medication adherence, and blood glucose self-monitoring. Storytellers provided consent through this process and had full creative control. So we noticed that a lot of them, because our stories were capturing these short videos, if you will, some of them had difficulties with their medication and with following up with the doctor because the insurance, because they didn't know how to navigate the healthcare system. So many hurdles that we noticed among our Hispanic Latino participants. And yes, so another thing that I want to highlight about the Hispanic Latino participants here, that they come from all walks of life. Some of them, like you hear Dino, he has his degree. Some people are field workers. And so the understanding of the diabetes was very, not everybody knew exactly the same. And it was a little bit of a challenge there to have that full understanding of what diabetes was and, their struggle with that.
Yeah. So I think you're really getting at the health issue that the Hispanic and Somali community highlighted, that there was limited knowledge, but also limited educational resources that were tailored. And so that's in 2014, that's what inspired the two stories that you saw. And so there were 8 people total who created stories. And we have links to those videos, including the ones you saw, as well as additional videos coming up in the presentation. So I'm going to jump into some of our case examples and how we tested those. So when we piloted the Hispanic and Somali videos, the Hispanic videos had really promising outcomes. So then we were able to successfully apply for randomized control trial funding to test efficacy. And we recruited over 450 people, Hispanic individuals with type 2 diabetes who had an A1C above 8, meaning it was not as in control as we'd like it to be. And we showed them the video in a one-on-one clinical setting, meaning the participants came in for a diabetes-related health visit to see their provider about really anything. And before or after the visit, a research staff person showed them this video. And we had good news. The people who saw the video showed a modest improvement in glycemic control 3 months after seeing the video. There was no change in blood pressure or body mass index, but people found it highly acceptable and said that it had high narrative quality, which goes back to that cultural centric health promotion model. That's the questionnaire that comes out of that model. And I asked people, like, do you identify with the characters? Are you engaged in the story? And people said yes, they identified and engaged. So we concluded from this work that the intervention was scalable, that it could be integrated into clinical and public health practice as part of diabetes self-management programming. And here are 2 papers that came out of that work. And I think Charlotte was maybe going to drop those in the chat for folks. Oh, yeah, look at that. Thanks, Charlotte. So if you want to dive into into the weeds, these are the papers. And our next steps with this component are we're combining forces with a group in San Diego to combine Stories for Change Diabetes with their app called Dulce Digital, which combines storytelling with self-monitoring and feedback about your diabetes numbers, so like your blood glucose. And so we're looking at if we put this story in there as part of the mix of that behavior change intervention does that make an impact? And so hopefully cross your fingers that that will get funded, because we would love to do that. So another thing that we did was look at, because our results were promising, we wanted to dig a little bit deeper, and we wanted to know, how do different sociodemographic or disease characteristics impact the viewer's response to watching the Stories for Change diabetes video? And I should say, when I say the video, I mean the story that you saw of the Hispanic individual, in addition to 3 other stories. And then there's an intro and conclusion voiced over by, by Graciela, which you can see, that sort of lays the groundwork, but then also encourages folks to manage their diabetes. And so if we know who responds better, we can efficiently direct this highly scalable intervention to those most likely to benefit. So that's where this work came from. So first, we determined of the intervention participants, the group in the randomized control trial that saw the video, who experienced a clinically meaningful decrease, meaning 0.5% in their blood glucose and their A1C between the baseline and the 3-month follow-up. And then we use multivariable logistic regression, which is just to say statistics, to identify factors associated with that clinical improvement. And we found that the folks who had a type 2 diabetes duration of less than 5 years and or showed improved self-efficacy between baseline and the 3-month follow-up, those were the people who showed improvement. And so all that's to say is that a tailored digital storytelling intervention developed with and for the Hispanic Latino community diagnosed with type 2 diabetes. We learned in the randomized control trial that it was acceptable and feasible in a clinical setting. And then this additional analysis added that it is effective at improving glycemic control, especially for those who were recently diagnosed in the last 5 years, or who showed through a survey measure that they had an increased confidence in their ability to manage the disease. And here's another publication that came out of that work. So, and I think, there's a QR code, and I think Charlotte was going to drop that one in too. Okay. All right. So we didn't stop there, because we know that quantitative measures, like survey measures that are close-ended, aren't always the best at getting at sort of the nitty-gritty nuanced details. And so we peeled apart the quantitative findings with qualitative interviews. And we broke the participants up into 4 groups. So stick with me. If you've ever taken epidemiology, think of your 2x2 tables here. So the 4 groups were the positive confirming, so the people who increased their self-efficacy and improved their A1C, the positive deviants, so the people who didn't increase their self-efficacy but did improve their A1C, the negative deviants who increased their self-efficacy but did not improve their A1C, and then the negative confirming, so the people who did not increase their self-efficacy and did not improve their A1C. So those were our interview groups, and we interviewed 3 to 4 people in each for a total of 14. So again, this is small, but qualitative. And although the randomized control trial, the gender breakdown was 60-40 women, men, we were not able to get any men to do the interviews. So no, at this point, we're only talking about Hispanic women with type 2 diabetes. So from this work, we were able to pull 5 themes that cut across all 4 of those different categories. And one was that social support is essential. And that was interesting because in the quantitative analysis, we had a social support measure and it didn't come up as significant. But in the qualitative, it was very clear that people appreciated and needed social support. And they talked about social support in beyond what you may be thinking of, sort of like familial support, but they talked about coworkers, they talked about neighbors and friends, children, church. Yep. So social support in like a broad thinking of that. A big thing that popped out was also how trauma shapes our readiness for change. And so there were examples of women who had experienced trauma a long time ago, like 20, 30 years ago, but the death of children, really serious things, and how those events inspired them to maintain their health today. But then in contrast, there were women who were living in really challenging moments and were like, this 12-minute video does nothing for me. Like this does nothing. Like I can't focus on that because I have these other things going on. And so, trauma was a big impacting factor, and depending on when it happened was key. All 14 of them, regardless of which group they were in, talked about caregiving responsibilities and how that can hinder our type 2 diabetes management. And that could be, paid positions, like people working in elder care were having trouble managing diabetes, but also people taking care of adult children, people taking care of children under 18, people taking care of spouses. So it was a lot of caregiving, which also gets into it's a very cultural role too for women
to care for the family. But another thing that I think is very important and highlight is sometimes people in the Hispanic Latino community, because of the immigration status, they lack resources in terms of health insurance or accessibility. So when they come to the doctor, if they come extremely sick, or they end up going to the emergency department. So that is a little bit different than the Somali community, because the Somali community comes here as refugees. So they come here with insurance. So there is a little bit of difference here that we've been able to see, the results as well.
Yeah. Another theme was persistence and how that's required for long-term behavior change, because diabetes doesn't go away. And so, there's sort of this, you got to reconcile with it, but then you got to figure out how to maintain your health and how hard that can be. And then finally, self-advocacy and a desire for knowledge drives success. There was one woman who talked about how she went to so many diabetes self-management classes that they gave her a certificate and you can't come back, you've done them all. And how that was really, really helpful, but also how informal knowledge acquisition can be helpful. One woman described herself as having really low literacy in Spanish, and how her neighbor, who was also diabetic, was able to teach her about how to self-manage. And so, knowledge acquisition in both formal and informal ways. So.
Medical literacy and that's very hard.
Yeah,
absolutely.
Yeah. So our takeaway from looking at this quantitative and qualitative results were that it really underscores the complexity of managing type 2 diabetes, especially as a Latina woman and as an immigrant with these multiple intersectionalities, like you're caregiving, you're working, you're a mom, you're a grandmother, you're a daughter, and how those shape our confidence in our ability to manage self-efficacy and health outcomes. So it gave us this sort of nuanced picture of those results. So the next steps that we're taking in this work is to look at delivery methods. So if you recall, we talked about how in the randomized control trial, people came in, they sat with the research coordinator and watched the video. So that's pretty resource intensive. You got to have a staff person there. So we want to see if we send it through the EMR, the electronic health record, or if we host an online facilitated discussion, does it have the same impact? And so I just got a grant to do this, but it's tiny. So we're hoping for a second one. The plan is we're going to form a community action board of Hispanic folks with type 2 diabetes. And, within our Rochester Healthy Community Partnership, community-based participatory model, that fits really well because we focus on equitable partnership principles, and we always strive to co-produce interventions and the services that the people most impacted would receive. And so we'll do that by considering the CAB members to be experts by experience, building on their assets, but also doing some capacity building around research training methods. And we'll work together to refresh and update some of the stories because they're from 2014.
Yes,
so we're gonna, and there's new things going on, like the GLP-1 injections and that kind of stuff.
So it's going to change the narrative.
Yeah. So we'll have to see. We'll have to see.
Abby, we have a couple of great questions in the chat for you. Irma asked, how did you choose which narrative to present? Did you gather multiple narratives or select one that was more relatable?
Okay, yes. Okay, so we have actually many people that apply or want to participate in the main group, that wanted to participate in this storytelling. So we needed to choose those ones that will resonate more with the community, those ones that their lives were impacted initially by diabetes and how they manage the diabetes after interventions. Something that will help future or people with diabetes to say, okay, that person was extremely sick, and now that person took her health or his health, again, and is in charge of, the medication and the diet, but not only by him or herself, but with the support of all the family, either in the Somali or the Hispanic community. Now, this particular story, I asked Abby, I would like to play Dino's story because not only I know this guy with the community, but I know he's still really participating in the improvement of his own health. So he's still, like I mentioned before, he's still playing soccer. His wife Vilma, which I also know, she is very responsible to cook and prepare the meals not only for her husband but for herself too and for the family, so they setting an example for the future generations. So that's why we thought, okay, this story is very powerful on its own, but now what that story brought to the family is to be more conscious about what could happen if you don't take care of your own health now that you're young. So it's just like extensive to all the family. Now, I suppose that Dino, being as part of this soccer group, or I think it's a team, I'm not sure, but it's a team. I think it's a team at the church. So I feel that Dino will have probably shared his own experiences with his friends when if somebody would come to him and say, hey, you probably know about diabetes. I was just recently diagnosed. Dino would probably share his story with that new person or a friend, and Dino most likely have also in his telephone the app, so he can show it to his friends or his family that this is what I did. I narrated my story, and you can watch not only my story but the stories of other people affected by diabetes. So it was not easy because we had other stories that were beyond, how can I put it? They were already very sick patients, if you will, very sick that their stories will not add anything to what we want to change. And those patients we couldn't recruit for the stories for change because we wanted to have those people that they really changed their narrative and they were having some improvement in their health. And what was the other question?
I think the other thing I wanted to say too is you're getting at like a logistics question too of like if you recruit a bunch of people and then some of the stories don't turn out, like what happens. And so what I've learned, and I think what we're going to do in the project I'm describing is probably make more stories than we actually need.
Yes.
And then what my mentor who's at ASU does is so I think she needed 2 or 4 stories, and so she pulled in and made 10, and then she had her community action board do the culture centric health promotion narrative quality survey for each story, and then it's sort of like a nice way to vote on like which one was better. And we had that with the cancer one. Yeah, I think we made 9 and we used 8. So yeah, it is it can be tricky to like navigate that.
Yeah, it is tricky because we want to make sure that with the cancer it's a little bit different because we needed to present people that they were still affected by cancer and other ones that wanted to prevent cancer. So there's going to be 2 things going on there. So but you have to wait.
Yeah. Okay. So I think Caitlin, I'm just looking at the questions. I replied to Caitlin that we're getting to the ethics later. Okay. And then Ming asked about, did you coach the storytellers? How would you ensure the scientific accuracy?
We did. So we brought 2 people from California. They specialize in storytelling. So they coach myself as part of RECP, I didn't have to coach anybody. I was there assisting them, making sure that they were able to take the pictures, making sure that they were able to navigate, they use the computers. But we gave complete, freedom to our participants. You will take the pictures that you want to take. First, they take, we coach them how to take pictures with their telephones. It's very easy. Okay, what do you want to show in that picture? What does that mean for you? So we want to have an idea what the meaning of the pictures were for them or what they wanted to communicate. In the same context, we wanted to hear what they want to say in their own words. Okay, if you were talking about diabetes, what do you want to say? what is going to be your story. So they actually, they also selected many of the narrations that they had. Um, we practiced with them, recording their voices, and we just selected the best pieces of their recordings and we embedded them into their videos. So the videos, they also were able to add the frames and add the music or add their text in each one of them. So they were completely trained to do that. I'm not sure if they still remember that, but they were trained completely, and it was very nice to see them, people that they never used a computer. They were sitting in front of a computer. They were able to type into the computer, adding pictures, again, with our assistance, but we were giving them that freedom and we empower them. Essentially, we empower them to do their own thing. And I think that was probably one of the nicest things that I could see when the people felt empowered to tell their story. I think that was absolutely beautiful. So yes, they were empowered and they were trained. Yeah.
Yeah. Charlotte, how are we doing on the questions? Did we get to most of them?
Yes, yes. Just one more from Irma was wondering, can you play the videos while the patient waits for the provider to come in the room?
Yeah, I mean, we could definitely do that. I think it's more about logistics and getting into the workflows because, again, what we're trying to do is a tailored story. And so this wouldn't be for all patients. And so we'd have to figure out some sort of like, how do we flag that this is a Hispanic person with elevated, which is like multiple components. So yes, and
I think so, triage. I think if they use Epic, with another project that I did with RCP, the patients were triaged through Epic, and then they say, okay, this is going to be a Hispanic patient coming to the clinic for such and such and such. So I needed to ask them some questions about, it was about diabetes too, actually. So, but it was not for the videos. It was about diabetes and control of diabetes, but different thing. So when I went to talk to them, it was just about some questions and but yeah, again, they were triaged through Epic and they needed to come to visit their physician for just a follow-up. And then after the physician finished the follow-up, the researcher came and then we talked about these questions and that was it. But yeah, it needs to be triaged before.
Yeah. So a possibility. Yeah.
There's a possibility. Yes.
All right. Let's keep going. But yeah, keep the questions coming and we'll keep trying to answer them. So thanks for your participation.
Yeah.
All right. So let me go back one step. This is, again, the next steps just got funded. We're going to look at delivery method. So what that's going to look like is we're going to pull, and this is just Mayo Clinic patients to look at feasibility. So if this is possible. So we'll pull people with who fit the metrics in the gray box. And we'll randomize them into two groups. So half of them get the video through the electronic health record, and then half will be invited to participate in an online facilitated discussion. The discussion itself will be the qualitative component of the green arm you see here, but the EHR piece doesn't have a qualitative component. So we're going to do some follow-up interviews just to add that to the orange arm. And then we have that baseline survey, 6 months and 12 months. Oops, I jumped back to 12 months. So that's the plan. All right. So all that was about the Stories for Change diabetes, but we did it again with
can be. So yeah, Stories for Change. So we already talked about diabetes. Now we're going to jump into, how we can prevent cancer, some cancers, obviously. So breast, cervical, and colorectal cancer screening saves lives. Disparities exist in cancer screening rates between Hispanic and non-Hispanic white populations. And there's something that I want to mention. Working at the clinic, sometimes I notice that even when the clinician offers the colonoscopy for some participants, they just are very hesitant to, to say, yes, I want to do the colonoscopy. They are a little bit afraid, especially the gentlemen. Women are a little bit more proactive in terms of their health. So they say, okay, yes, I want to have the pap smear or maybe the mammogram. But in general, what I have noticed working with so many patients at the clinic is that men are a little bit more difficult to convince in terms of cancer screening prevention tests. So, but we're working on that. Okay. So again, they are a little bit more difficult, and sometimes even women, they wait a little bit long to get tested.
Mm-hmm. Yeah, there's disparities.
There's a disparity. They don't have the information on time, or they just don't go to the doctor, and then a lack of knowledge, if you will. Yes.
Yeah.
So again, some of the challenges, is finding the storytellers, and we're going to talk about some of them in a minute. The storytellers, well, they worry about whether their story will be a good fit or not, and the process felt rushed for those with less tech experience. We talked about that already, and then you can see in that computer we actually helped them a little bit, but they were on their own most of the time. Wanted the final story more quickly after the workshop and more interpretation support. I was during this time I was doing both things. I was a researcher and I was an interpreter. So for me it was a little bit more complicated. A lot of the participants spoke only Spanish, and then we needed to have somebody sitting with them interpreting our presentation, and sometimes helping them with the computer, which it was in English. Yes, the process has sometimes rushed, and we probably needed more facilitators and definitely more interpreters. I brought one of my colleagues was one of the participants actually, and he said to me, you are doing a great job, but I think this type of research, when you're working with so many people, they need almost one-to-one interpreter, because they are going at their own pace. So you cannot put everybody together and you expect everybody going, at the same pace. Maybe this person was working in the picture and the other one person was working on the dialogue, and then they felt rushed because we didn't have enough support.
Yeah. So we had. So these are the challenges and opportunities from doing the Stories for Change Cancer workshop. And we, like you're saying, we had a really wide, I think possibly the most wide as possible range of digital health literacy there. Like I think 2 participants we had to set up email accounts for, because they didn't have email accounts. And then another was like a professional photographer who could upload So
everything.
Yeah.
So it was complicated. Yes.
Yeah. And I think one of the, like you were saying, more one-on-one feedback, and we talked about more of us doing the facilitator workshop. So so there were multiple facilitators, not just the story center.
Yes, exactly.
Yeah.
So it's something that you have to take in consideration if you're planning to do something similar, to have interpreters on board and the facilitators and additional help.
Yeah. So I think next you're going to talk about opportunity. Yeah.
Yes. Well, let's talk about the opportunities. Yes. Well, I mentioned that before, the storytellers felt empowered, and they really liked the workshop facilitation, and they made new friends. That was very, very, very nice. And then they obviously appreciated. So when we were doing this workshop, the people were sharing their stories. They felt empowered. They felt that somebody was hearing their voices, and they hear their suffering. There were many tears. I want to say that. It was led in a sensitive manner. It was a space for vulnerability. It was. Some facilitators made time to work one-to-one, but not everyone. Share stories were similar to others. We share meals inspired by others' resilience. I want to go back to the share meals. We had in this group, we have to divide the group in the Somalis and the Hispanic, some male and female, and then they also share, some of the food that they brought with them to share with the community, with us, and we also brought some food. So again, food was a component in this workshop. They really talk about that. And then the final story screening, it was a chance to remember loved ones who passed, reflect on their own struggles and strengths. So there are so many stories here that, I don't know how many times we cry every time we see these stories. They're very moving. Some, again, stories that helps you to think, when do I need to start going to the doctor to prevent myself to developing some cancer and not to have a scare. And or at the same time, when was the last time we hear some stories from somebody that they took so long to go to the doctor and then the family member passed because they never had time.
Sure.
And so
Sure.
if you will, Abby, I think we want to go to the next video. And I think I asked Abby we could play this one. This is extremely moving. So
Yeah.
prepare your tissues, please.
Yeah. I before I play, I just want to give a huge shout out and high five to Katie Smith, who coordinated that whole workshop and deserves a lot of credit. I know she's on the call, so we appreciate you. So this project isn't quite as far along as the diabetes one. We described the challenges and opportunities from building the culturally tailored video through the workshop with Story Center. And then we pilot tested the videos with like 12 to 13 folks, and I'll show you some of those results. And we are currently waiting on some funding, waiting to hear if we get some funding to test the effectiveness. So again, to do a larger randomized.
And I want to mention that some of our stories for change for cancer, some of them actually talk about some participants that they actually listen to their healthcare provider and say, okay, you are 50 or 55 or 60, you need to get a screen for that and that, right? So those participants went get a screen, and guess what? They found something like a polyp, and then they have to remove the polyp. And then after that, that participant was saying, oh my gosh, I am so thankful that I listened to my doctor because probably I was able to prevent some colon cancer. So they, like I say, there are two types of stories here. So that's why they are so important.
Yeah, we recruiting was hard. Going back to the opportunities, we originally wanted only cancer survivors, but we weren't able to find people who are willing to do it. So then it switched to co-survivors, meaning family members. So Celestina was a co-survivor. But then we still needed a couple more people, so we did recently screened. So one of the videos is from someone who's not a survivor. He just recently screened. That's and sometimes you just have to pivot, much like with our technological challenges today. But that's just part of community engaged research, as I'm sure many.
But they give very positive results because then you can play that video potentially to somebody that goes to clinic and say, if that person was able to prevent cancer just by getting the test done, why shouldn't I?
Yeah, that's the hope anyways. So let me share some of the pilot test results with you. We asked viewers, the people who saw the videos, whether they intended to complete screening, and all of them did, which you should, take that with a grain of salt because of social desirability bias. We were showing them a video and then being like, do you like it? Which is part of that process. So again, why we need some effectiveness testing. We asked them also if they felt more motivated to get screened, if they were more confident, and if they found the video useful, and almost everybody across the board said yes. So then when we looked at after 7 months, whether they actually got screened, over half of the colorectal cancer video viewers were screened, and about half and about a third for the breast and cervical cancer, respectively. So I know we've talked about type 2 diabetes, and we've talked about breast, cervical, and colorectal cancer screening. But in the chat, what other health topics do you think could powerfully be displayed through digital stories?
Let's see the answers.
Your work.
Yeah, we want to hear. Seeking care for mental health. Yes. Vaccinations and immunizations. Absolutely. Yes. Yeah. Postpartum depression.
Ooh.
Yes. There are some videos in the dementia, substance misuse treatment, menopause. Yes. Taking care of yourself during through menopause, lack of support after pregnancy, obesity and its complication. Absolutely. Yes. Caregiving. Caregivers are always, struggling also, equity and accessibility rooted issues, such as feeling exclusion in space, during planning for families with loved ones with disabilities. Yes.
Youth commercial tobacco. Yeah, I see you, Katie Smith.
You're giving us a lot of ideas. Caregivers of nonverbal children. Absolutely.
Yeah. Yeah, so this is medium is really flexible, HIV stigma. Yeah, I know it's been done a little bit. I think actually, Charlotte, one of the articles I sent you, and I don't think I have a QR code for, is the scoping review, and that includes what other folks have done, which I think is from like 2022.
Addressing mistrust with the medical system, big one, super big one there, right there. Yeah. Yeah. Okay, cool. Thank you.
Well, thank you for your creativity. And there's the scoping review. So this is a couple years old, but it's has examples of other research groups that have done digital storytelling interventions. So a question, digital equals video, are other mediums to consider? So we, in the scoping review, define the digital storytelling in a really specific way that the people have to, it can't be like a documentary where the videographer has the control. It has to be set up like Story Center sets it up, where the people most impacted have control over their own stories. And we do include some educational components more so in the cancer videos, which you also narrated, about, what is a pap smear, what is a Cologuard test, just so they have some understanding of what we're promoting.
One of the things that I remember from the very first one, from the diabetes workshop and the cancer workshop, that the people that came to train us, they told us very specifically, we want to hear the voices of the participants as they are. We cannot change anything. We don't care if the participant speaks in perfect Spanish, meaning they might have, grammatically, they might not be, they might not speak correct Spanish, if you will, right? Yeah. But that's exactly the way that that person is communicating. And I am pretty sure she told us that a lot of people speak just like them, and they will be able to identify themselves. Versus, we try to tell them, no, you have to read it like this perfectly, and perfect grammar, perfect grammatically correct Spanish. No, it was just, how they speak without any changes.
Yeah. And so that was, you were thinking for the diabetes video, right? So we showed the colorectal cancer screening promotion video you saw to our community action board at one of our partners, Mountain Park Community Health Center, which is in Phoenix. And they had a similar response that they felt like the storytellers were really relatable, like they were like people they knew. And that a lot of times in our culture, Hispanic or Latino people in the media are sort of displayed as like, they're like Shakira, or like these like sort of perfect people. But when we were able to show an immigrant who's working a blue collar job, like that was much more relatable to people than the newscaster, the singer, celebrity. Yeah.
Oh, how can we balance the perceived relatability and the reinforcement of
that's coming? We're going to talk about that. Okay. We're going to talk about that. Okay, so let's keep going. Okay. So ethical considerations, and I know there were a couple earlier. So we're actually going to put it to you first, and this is our last question. What do you think is important to consider when creating digital storytelling interventions when you're thinking about ethics? And Ming brought up a really good point about avoiding reinforcing stereotypes, or if you are going to reinforce a stereotype, like what to do in that situation. So what other ethical considerations? And I see there's another question, but we'll get to that in a minute. What ethical considerations do you think there are when you're creating a digital story?
Okay, that's a very good question there. We can get back to that one.
Sure.
Feels coerced, into making the videos, absolutely.
Yep, we don't want people to feel coerced.
People the autonomy to tell the story they want. Yes.
Yep.
Versus we represent them.
Yeah.
Power sharing and ensuring the storytellers has ownership. Yes. Not for the stigmatized community. Exactly.
Yeah.
As we mentioned, making sure that not to reinforce stigma, biases.
Yeah. Those are all great responses.
So what was the other question?
Let's do this real quick and then we'll come back.
Make sure to the family friends who discuss giving permission and
making sure everyone's given permission, full control. Yeah. All right. So seminal work in this sort of niche space of the ethics of digital storytelling is from Aylin Gubrian, who's at the University of Massachusetts and has done a lot of this work, primarily with Puerto Rican teenagers who are pregnant. And she came up with these 6 things to keep in mind. So acknowledging the fuzzy boundaries that are inherent to projects with competing interests. So you've got your research interests and maybe some like advocacy pieces, but then also the goals of the intervention. And so one thing to consider is having a memorandum of understanding or some sort of paperwork that explicitly states how differences of opinion will be addressed and how to deal with sticky situations. All partners should be in agreement about the goals, objectives, policies, and procedures of the project. And like one of you said, the recruitment and consent, we want to make sure that all the participants feel comfortable telling deeply personal stories, but also acknowledging that it is personal and it could potentially be triggering. And we want to critically engage with potential participants about the realistic benefits and potential risks of participation and provide cultural safety and supports if needed. So that could be, like a list of mental health resources. It could be elders present or counselors present in some situations. And then, as someone mentioned, optimally have oral or written consent from all those featured in a story as well. I think people talked about power shaping as well, in which, sometimes we as facilitators are more powerful than we think we are. And we may unintentionally influence the narrative content despite our intentions. And so we need to take a reflective approach on issues of power and really embrace our sense of humility and that's really key to facilitation. And I will say the Story Center folks are very good at that.
Fantastic, yes.
And really keeping the storyteller's well-being and autonomy of voice at the center of the project. Representation and harm, recognizing that stories can reinforce stereotypes or unintentionally expose participants to others' risk. So in addition to what we've already said, the facilitators can engage in critical dialogue with storytellers or audiences to challenge the message and really think critically about how we're presenting things to challenge those stereotypes. We want to have confidentiality. It's, given that digital media often cannot be fully de-identified or especially once it's been shared or really controlled once it's been shared. We want, participants to go in knowing like, how that they'll be credited for their work by name if that's what they want, or a pseudonym if that's what they prefer, and that they'll really maintain ownership over that process. And then finally, the release of materials, so emphasizing that that consent for creation does not automatically imply consent for future use or distribution of their story. So just being really explicit about the where, why, how, and by whom the stories are released, and that can be negotiated, and that it's an iterative and ongoing process. And so to do that with the Stories for Change Cancer Prevention Project, we had a pre-digital storytelling workshop orientation where we walked people through the consent form, what we plan to do with the stories. There was space to ask questions. It was in Spanish, so it was in their native language, and so they could ask and understood everything. And then after they'd made their stories, we came back again and said, okay, now that you've done the whole process and like understand what that was, do you still want to participate? Do you still want to share the stories in this way? And they all came back. And I think, it's really powerful to, be working towards change, to know that your story in that way can persuade others to potentially save their lives, I think is a really powerful way that people were thinking about it. So the tools that we welcome you to use are the Stories for Change Diabetes video that we shared earlier. So here's the QR code again. We cannot, and that site has the Somali and the Hispanic videos. We can't share the cancer videos yet because we haven't done the efficacy or effectiveness testing, I should say. And so we got to keep those in-house. But someday, hopefully soon, those will be public. So yes, please feel free to use those in your work. If you want to create your own digital story, I would advise taking the workshop from Story Center. I dropped their link in the chat, I think earlier, but I'm happy to do it again if that's helpful. But that's really the way to go. They're the experts, and they have a digital. Oh, thanks, Charlotte. They have a story workshop where you create your own story that I actually just took and was really great. But then they also have a facilitators workshop that I think somebody mentioned they had also taken. So so our takeaway today is really that a tailored digital storytelling intervention developed with and for the people most impacted can be an effective tool for health promotion. And so with the diabetes video, we learned that it was acceptable and feasible when delivered in that one-on-one clinical setting, and it was effective in some modestly improving folks' glycemic control. It was most impactful for the people who were recently diagnosed, as well as those who showed an increase in their confidence to manage their type 2 diabetes. But we know also that that is influenced by multiple intersectionalities that shape our confidence and our health outcomes, and that those are ever evolving and ever changing. It may be digital stories may be effective for cancer screening promotion, TBD. We'll get back to you once we know. And then those ethical considerations should always be at the forefront when we're creating digital storytelling interventions. Do you want to add anything to that?
I think we have everything. Okay. Yeah. One of the things that, when I was reading through the videos and the ideas for new storytellers,
sure.
And there are so many, potentially we could, make stories for everything, right? And some of them were coming like, what about postpartum depression and, the tobacco cessation, whatever. So in the postpartum area, my experience working with patients there, that my saliva. There are some videos that they present to moms and dads after the baby is delivered. Oh, yeah. However, a lot of those videos are not exactly storytellers, narrating their story. They are more institutional, like very didactic, and the patients, they have to see it as a homework.
Yeah.
And then they don't discharge you if you haven't seen those videos. But I wonder if the idea to present videos is fine, but maybe they can do it, take a step back and say, we can present something more like a mother, talking about her own experience about depression, right? How it feels, how it's going to look maybe in 2 or 3 or 5 weeks from now. So that could potentially be one of them. And I think that's,
that's a good idea.
Yeah, I think when it's very didactic, it loses a little bit of the vibe. It loses a little bit of the, I don't know, the feeling. And to me, the stories are more my friend, my neighbor. I can relate to them, and especially if it's in my own language.
Yeah. All right. Well, this story is not yet over, but it's already showing some promising results. So we encourage you to use those tools that we described earlier. And thank you for your time today. We're just really honored to be here. Thank you to the Bright Spots folks for the opportunity.